Hi, this is Brian Kim. I want to share with you case number 195 in the best way to do cataract surgery series. This is a 1 to 2 plus dense lens, and you're going to see evidence for zonulopathy throughout the case. And then you're going to see how I load a capsular retention ring and how I like to use a Lester hook to dial the CTR into the capsular bag in such a way that it doesn't cause any rotational traction. You can also see the Hydrus microstent placement and double chop, cross chop, and mechanical fracturing techniques to utilize less ultrasonic energy and hopefully lead to clearer corneas postoperatively. This is a corneal marker which will help me to center and size the rhexis. Use a cotton tip to steady the eye and control the eye. And then I make my paracentesis incision first on the right side, and then I go ahead and make the Hydrus microstent incision. I realized by placing the incision ahead of time, this helps reduce the risk for hemorrhages at the time of stent placement. You can see this patient has quite a bit of a vascularized cornea, and there's quite a bit of hemorrhage coming out. Make my paracentesis incision on the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready, I enter. These are the sharp tip Haldey-Perkar forceps. I go in sideways, puncture the center, and the sharp tip forceps act like a cystotome. I'm able to control the tear, grabbing the right side of the tear, going around circumferentially, grabbing and re-grabbing. Again, these low profile forceps are really nice. They help reduce OVD egress and help maintain a stable chamber. And I'm going around circumferentially, making the rhexis match the size and centration from the corneal mark that I made earlier. Finish off the rhexis, burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, point the tip back up, decompress on the left side. I'm trying to decompress the best that I can, but you can see that it's not really allowing me to, and that's because of some zonulopathy. And so that's the first key, is after you do hydrodissection, you try to burp the hydrodissection wave out of the bag, and when it doesn't want to, that's because there's not enough counterforce from the zonules to allow it to keep the bag in place. And all you do is you just stretch the zonules as you're trying to decompress the bag. So that's sign number one. Irrigating the surface of the eye, adjusting the sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Look how jiggly the lens is. And that is, again, a sign, zonulopathy sign number 2 of this case. Placing the chopper around the lens, hooking the peripheral lens, turning the phaco tip vertically subincisionally, fracturing the lens completely in half. That is double chop. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, crushing the lens against the phaco tip like it's a chopping block, and that is cross chop. Getting the chopper around that first quadrant, fracturing the lens completely in half, utilizing ultrasonic energy and vacuum to emulsify the lens piece. I'm loosening up that second quadrant and then placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip, and then using some vacuum to grab that piece, and then the other piece, getting around the piece with the chopper and crushing the lens into smaller pieces, and then emulsifying the lens piece. Using some vacuum to lift that second heminucleus up, getting around the lens with the chopper, crushing the lens completely in half. Again, successive crushing forces, crushing the lens from either side with the instruments, and then emulsifying the lens pieces. Very controlled way, easy way to disassemble the lens. Again, I'm getting under the lens. You can see I'm holding the chopper sideways. This is a very efficient and kind of a safe way in case you're not feeling comfortable keeping that chopper pointed towards the nerve. Using some vacuum to pull the epinucleus up. Oftentimes in these cases where it's difficult to spin the lens, you can see that the epinucleus is rather stuck to the cortex. As I lift it up, I place the chopper deep to protect the posterior capsule, making sure it doesn't come up with the epinucleus. Carefully removing the epinucleus, sliding the chopper around the epinucleus on the right side, hooking the epinucleus up out of the bag, and then using the vacuum to grab the epinucleus up. Very safe way to tease the epinucleus off the cortex and the capsular bag. That's the end of the epinucleus removal. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. But before I do that, I go ahead and cut the conge at the main incision with the forceps because there was a little bit of ballooning. Removing the cortex, starting subincisionally, peeling it from anterior to posterior. As you see, as I'm peeling, you can see there's a little bit of loss of resistance as I'm peeling the cortex. You can see the bag collapses a little bit as I'm pulling, and that is zonular weakness sign number 3. Sign number 4 is you saw I was able to peel the cortex off the posterior capsule, and you can see the posterior capsule dimples and kind of puckers into the port, and that is sign number 4. And so I'm polishing under the rhexis edge, polishing the lens epithelial cells, and now I'm polishing the posterior capsule. And as I polish the posterior capsule with the polish mode, you can see the puckering of the posterior capsule into the port. Again, that is the 4th sign that there's some zonulopathy in this case. I'm very careful and methodical of peeling off that fine lens material. Oftentimes, these cases where the bag is rather loose, there's a lot of cortical material that's kind of stuck to the bag. Again, that's because it's loose. And because it's not able to provide that counterforce with tight zonules, since it's not tight zonules, it's loose zonules. And when you go after with vacuum, naturally it will collapse because you don't have that counterforce. I'm pulsing BSS into the subincisional capsule fornix, making sure infusion is on during that maneuver, keeping the bag nice and inflated. And then I'm going to turn off irrigation quickly and push cohesive viscoelastic to fill the bag, but I'm keeping the INA tip in to plug up the main incision. And now this is the CTR, and I'm doing this with the assistant holding the injector holder, and I'm going to just rotate the CTR in place. You can see that rectangular groove there. I'm going to align the hook pointed down, align it parallel to the eyelet, hooking it down and making sure I'm aligned appropriately, and it goes nicely into the injector. As the injector comes out, you can see I'm going to hook the leading eyelet with the Lester. As it goes in, you can see I'm able to collapse the diameter of the CTR so it doesn't cause any torsional stress on the bag, and then I disengage the trailing eyelet into the bag. This is a single piece acrylic lens. It's going into the capsular bag. And then because I'm going to be placing a Hydrus microstent, I use a Lester to dial the haptics into the bag. And remember, the CTR is not going to necessarily prevent late lens and bag dislocation. It's supposed to be so that you can use the CTR and lasso it to the sclera in the future if necessary. So injecting some cohesive viscoelastic into the anterior chamber and on the cornea, making sure the Hydrus is actually there at the tip. I go in with the Hydrus into the incision that I made earlier. You can see still there's some interface heme there, but it's good that I made my incision early on, which reduced the heme. Place the gonio lens on. go ahead and stab the TM with the injector, advance the stent. I'm going to flatten out right here, and it's going in nicely. Push it all the way out, and then I'm going to try to push that notch and see if I can push it in even further. I'm going to try again. Go in with the INA, activate irrigation, getting underneath the lens, tilting it and rotating it, removing the viscoelastic from within the bag. You can see the heme coming out from the Hydrus, which tells you that I'm in proper position. Switching to polish mode, polishing underneath the rhexis edge. Switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a 1 to 2 plus dense lens. You saw evidence for zonulopathy. Number one, I had difficulty decompressing the bag after hydrodissection. When the BSS is trapped in the bag, when you try to push down on the lens, it's supposed to just burp out. But when you have zonulopathy, all it does is just kind of stretches the zonules. It doesn't actually have enough counterforce to hold the lens in place. So that's number one. Number two, when I started to remove the epinuchal material, you saw the whole lens was jiggling with that high vacuum. After the lens came out, when I was peeling off the cortex, you can see the lack of resistance as I was peeling with the peeling force. The cortex from the bag, it was actually causing the bag to kind of collapse into the port. When I went to switch to polish mode and I was polishing the posterior capsule, you can see the capsule puckering up into the port. And so that's sign number 4. So I placed the CTR, again, using the Lester and then using an atraumatic technique of dialing the CTR into the bag by retracting it in such a way that it doesn't expand fully, and then placing it into the bag. And then, of course, my Hydrus technique, the biggest pearl is place that incision for the Hydrus early on in the case. And of course, I had some ballooning. If you have ballooning of the conj, don't worry, just go ahead and cut the conj. And you saw this patient did quite well. The CDE was rather low. The patient had a nice clear cornea, and then thankfully also better controlled pressure with the Hydrus microstent. So I hope this was helpful to you, and I thank you for your attention.